Hi there. Can you please change your name to your real name? Otherwise, I have to remove you. Galaxy J7. Can you type your name or text me your name so I can change your name? Thank you. Hello. Do you hear me? Galaxy J7. Hello? Galaxy J7, do you hear me? Galaxy J7, do you hear me, please? Galaxy J7, do you hear me? Or can you please text me? I already texted you. Galaxy J7, if you don't reply, then I have to remove your name, unfortunately. Well, do you have a question?
Hello. Hi, Doctor.
Do you have a question?
No, but I need to know more about the basic of ventilation. I have a CPAP in our unit. With the CPAP, there is a ventilation part. This
I didn't
mean,
understand. Can you please like type? Can you type? I
okay,
didn't understand the question.
yeah, okay. I have a CPAP in our unit. CPAP in our unit.
Okay,
There is a two mode of CPAP.
okay.
Mode of CPAP and the other mode ventilation, which
So
mean
it's,
that
so it's not CPAP then.
yeah,
It's a ventilator, right?
no, it's CPAP. But in the CPAP have two modes: mode of ventilation in the nasal, and the other mode, right about in ventilation, which means that.
Uh, I don't know. Maybe ventilation means advanced CPAP or PIPAP that we talked about, which
Okay,
gives you PEEP and give you CPAP and also give you some breaths. I think so. What we call it
okay,
non-invasive ventilation. Maybe I'm not sure, but if you send me a private message about
yeah,
like the model type and what you're talking about, so I can
okay.
figure it out.
I'll be take the picture of it tomorrow and
Yeah,
we'll send the private. Okay.
sure.
Yeah. Thank you.
Thank you. Okay, iPhone. can you please change your name or send me your name so I can change it? I need the name. I cannot put person with a name iPhone because I need to know if somebody did something wrong. I need to know who's that. So either you change your name to from iPhone to your real name or text me your name. Okay, Mona. Okay, I will change it. Okay. Next time, please try to change your mobile name. Okay, Mona, got you. Good. Okay, great.
Torek, I can ask you some question?
Yeah, go ahead, please. Wael, right?
Okay. Yeah, yeah. I
Yeah,
have
go
in
ahead.
my unit, in MQ unit, I will be give surfactant newly
Okay,
before 2 weeks. Okay.
okay.
When I read the surfactant taking, there is a mode of entrance of surfactant about duration about half to 1 hour. Is it true or not true? I asked some question to the special unit about the neonatal care unit. They told me, I think for 5 minutes just duration. It's true or not?
The timing of the surfactant is three types. The
Yeah,
first type called prophylactic,
yeah,
um, and the second one called early rescue, and the second one
late.
called late rescue.
Yeah,
So, um, um, sorry, I'm just trying to help others. Give me 1 minute.
okay.
Um, Infinix04, can you please change your name or send me your name so I can change your name? Otherwise I have to remove you from the meeting. Infinix04. Sorry, Wael. So
Yeah,
there are three types of surfactant regarding the timing. So you give surfactant either early rescue within 30 minutes or late rescue within 2 hours of life or early rescue within 2 hours of life or late rescue which is in the first 8 hours of life.
yeah,
Regarding the duration of surfactant depend on the type of the surfactant. So if you're talking about Survanta, it's a 3 ml per kg, so it takes time. So the best way to give it, it depends on the way. You're giving it a closed method or open method, using hand ventilation or ventilator.
hand ventilation, hand
Yeah,
mask,
and
just
it
hand mask.
and it's open, right? Open method, right?
Yeah, yeah.
You're
Mask ventilation, just by
no,
the by my hand.
you cannot do mask ventilation because you have ATT, right? So it's not
Yeah,
mask
yeah,
ventilation. You mean hand ventilation.
yeah,
So,
yeah,
because you're doing open method, and when you install the surfactant, it will take time to ventilate because you're not ventilating during that time. So I advise you to make it two aliquots, two parts. The first part you inject and then bag, and the second one. Now, how fast you give it? As fast as possible. But you have to prevent the surfactant from coming back to you. So if you see the
yeah,
surfactant coming back to you, you have
yeah,
to wait until it goes in and then inject, and then connect your handbag again and ventilate. So I advise you to give it to two aliquots, two parts. So let's say 2 kilogram baby,
Yeah.
4 mil per kg, 8 mil. The first aliquot 4 mil, the second is 4 mil. Now the best timing is between 30 minutes to 2 hours, early rescue. Prophylactic is not good, late rescue is not good.
Yeah.
Okay, so the
But
timing is between 30 minutes of life to 2 hours. That's the best timing. The duration is you divide it to two aliquots. The first one you give it as fast as possible, but the surfactant should not come back to you through the ETT. If you see it coming back, you wait. So then you determine that minutes. Usually it takes about 2 minutes, and then you cannot go more than 2 minutes because the baby is apneic. Uh, so the
yeah.
shorter the better, because you're using open method. If you're using closed method, you can go as long as that, because you can ventilate and give surfactant at the same time. Because you don't have the MAC catheter, or what they call it, multi-access catheter. I've already discussed that. If you go back and listen
Yeah.
to the
Yeah.
presentation
Yeah.
about the Ensure, and there is a video how to give it. So if you're using the open method, then the best way is to give it to two aliquots. Each injection or each administration should not exceed 2 minutes. Shorter the better. However, when you inject, your surfactant should not comes back to you. After you finish the first aliquot, you disconnect the syringe from the ATT, or you take the feeding tube out, connect to the ventilator, do hand bagging until you clear that surfactant. Baby's baseline vital signs goes back to normal, like saturation, heart rate, and whatever,
Yeah.
and then give the second aliquot. Okay? Does that
Okay.
answer
Okay.
your
Okay.
question?
Duration of operation about 5 minutes all the time. The first one and second one.
No timing. There is no
No
timing.
timing.
It's
Yeah.
on tolerance.
Yeah.
So
Yeah.
when you inject, you should give it as short as possible.
Yeah.
Got
Yeah.
it? But if you're giving it as short as possible, but the surfactant coming back to you, stop, disconnect, bag, and give again.
Yeah. Yeah. Thank you. Thank you,
Yeah.
sir.
If anybody knows who is Infinix 40, he need or she need to change her name. And Seja, you need to turn off your camera. Your camera is on. So I've turned your camera twice, and you put it back on. There is Infinix 40. Can you please change your name? Infinix 40. If you don't, send me your name. I can change it. Otherwise, I have to remove you. Infinix 40. Infinix 40. Can you please change your real name or send me your name so I can change it? You can text it to me. I've texted you twice. I have to remove you if you your name is there like that. If anybody knows who is Infinix 4, please tell him to change his or her name. Any question? Anybody has any question? Infinix 40, I have to remove your name. Okay. Infinix 04. Infinix 04. Can you please change your name or text me your name? Otherwise, I have to remove you from the meeting. We'll give you 1 minute to do that. I've texted you also to the groups. Infinix 04, can you please change your name? Infinix 04, can you please change your name? I have to remove you. Infinix04, do you hear me? Please do anything. Send me a text, raise your hand, do anything. Infinix404, please change your name. I have to remove you. I'm going to remove you. Okay, I'm going to remove you. Asil, can you please put your full name? Asil, can you please put your full name or text me your full name? Asil, can you please write your full name? Okay, Asil, thank you very much. I'm going to change your name. Thank you very much for changing the name. Thank you very much. Okay. Very good. Any question? Anybody has any question about the previous talks about ventilation? Anybody has any question? There's a certain number of people who has no not activated their mic yet. So, but anybody has any question? Shema, you can turn off your camera. Shema, turn off your camera, please. Shema, turn off your camera, please. Any question? Nobody has no questions? Okay. Well, I'm very happy that, guys, you don't have questions about ventilation. Let's start sharing them. Now, if you don't see the presentation right now, tell me, please. Any questions? Nobody has any question? Any question? No questions? No questions? Nobody has any question? Or 20 participant has no question? Okay. No question about previous talks? About ventilation? We have 3 more minutes. Well, thank you for everybody correcting the name so I know with whom I'm talking. There's a group of people who who do not have the mic activated, and these are Iman Al-Inani, Noura Mahmoud. Noura Mahmoud and Iman, both of you did not activate your mic. Relation between hemoglobin and, yeah, it's very important, because remember that hemoglobin carry the CO2 and the oxygen. Okay, so and there is percentage of oxygen being able to carry oxygen. There is ability of the hemoglobin to carry, and when you do blood gas, can you please turn off? Anybody is here? Can you please make sure that your mic is off? Hello? Can you please turn off your mic? It's simple. So when the machine set, it has a certain level of hemoglobin. So when you enter the data, you enter the temperature and the hemoglobin. The machine has a number of hemoglobin. The usual, they put between 12 to 16. And that will measure the oxygen depending on that level. So, for example, in neonate or in hemoconcentration in dehydration, you have a higher hemoglobin level. Let's say it's 19. And that will give you less level than the reality. So you have to correct that. So if you have to correct when you have anemia or you have polycythemia or high hemoglobin, you have to correct your hemoglobin level. Oh, lactic acid is metabolic. Lactic acid is metabolic. It's a side product of metabolic, while pH is acidosis. pH is acidemia, is the presence of a substance that can donate hydrogen. Lactate is one of them. So not all acidosis having lactic acidosis. And lactic acidosis are of two types. Primary due to metabolic, a secondary due to perfusion. Also, the lactate is of two types, the L-lactate and the D-lactate. And what we're talking here is L-lactate, not the D-lactate. The D-lactate has other advantages. So when you measure the lactate, make sure you have not a metabolic, which is very rare, and then you have perfusion. So if you have acidosis and lactate is high, meaning perfusion is not good. So you have a septic shock, or you have a drug, or you're premature and you don't have, or you have asphyxia, and your lactate is high. So when your lactate is high, it's perfusion, and less commonly is metabolic. While when you have the pH is high, that's a different story. In non-ketotic hyperglycemia, which changes associated in acid-base balance? Oh, that's a different story. Now, this is not an interpretation. This is a case scenario. We can talk at when we talked about non-ketotic hyperglycemia. I don't think the time will give me the room to discuss that. So I'm going to start today's talk. So my name is, again, Yahya Ithawi, and I am a neonatologist and a general pediatrician. And today's episode is one of the series about ventilation. Series of ventilation. And today we will be talking about how, after we finish the basics of ventilation, and after we finish also interpretation of blood gas, today we will be talking how to set, and then how to maintain, and then how to wean the ventilator. And when you have asynchrony between the patient and the machine, what you will do. So please, do you hear me and do you see the presentation? If no, if yes, you don't need, but if no, tell me. If no, you don't need, if yes, don't need to text me, but if no, text me, please. If you don't see or you don't hear. Okay, so the objectives of today's talk, oops, sorry. So the objectives of today's talk is um, uh, we will talk about initial setting of the ventilator and then how to recruit lung and what is the best PEEP that you can use and how to maintain ventilation. And when there is synchrony, asynchrony, what you will do, a troubleshooting a little bit. And when you have abnormal gas in a ventilated patient, what you will do, how to wean from ventilator, what is the complication, and then how to extubate. Now, initial setting, you need first to select the type of the ventilation. Is it like pressure controlled ventilation or volume controlled ventilation? And then you need to select the mode of the ventilation. And then you need to set the PEEP, PIP rate, inspiratory time, and volume guarantee if you are using combination of ventilation. What is your trigger? What is the type? And what's the level? How to control, what's your control variables, and what is your phase variable. For those who are missing control is how to control different parameters. Phase is how to change the respiratory cycle between inspiration and expiration. Now, lung recruitment. Lung recruitment meaning is you want to expand the alveoli, a collapsed alveoli. And after you recruit, you need to maintain open by adequate PEEP. What is the benefit if you're open the alveoli? So imagine you have a balloon and it's completely deflated and you're trying to inflate. At the beginning, you will have a difficulty. If you deflate again and try to inflate again, you will have same difficulty. But if you keep certain amount of air inside it, it will be easily to inflate and deflate. That's the whole principle. Now, when you have a good alveolar opening, you will have a good contact between the alveoli and the pulmonary vasculatures. And then all the blood in the pulmonary will contact the alveoli and do the gas exchange. If the alveolar size less than the pulmonary vessels, then there will be no contact. So the best contact is full contact with alveoli, between the alveoli and the pulmonary vasculature, and therefore you get better oxygenation. As we said, when you have a good PEEP, the opening and closing, expanding and expanding is better. And therefore you need less pressure or PIP pressure to open the alveolar when you use a good PEEP. And you prevent the cycling that I was talking about. Opening the balloon and closing the balloon. Opening, you keep it open so you remove this cycle. And secondary lung disease. Always when you ventilate, you get collapses. So if you use a good PEEP, you prevent secondary disease. So if you have RDS or adult respiratory distress, and you use a good PEEP, you will have less incidence of secondary collapses. Again, you will prevent pulmonary shunt because you have a good contact. Because if the alveoli less than the size of blood vessels, the blood will move from artery to the pulmonary vein through the capillary without contact, so causing intrapulmonary shunt. While if the contact is good, that won't happen, and they improve oxygenation. Second, good PEEP, have a good compliance, then you need less PIP. Second, third, you will not close the alveoli, so you don't need to open it again. Third, you will prevent secondary collapses. Is everybody hearing me or no? Do you guys hear me? Can you
Yes,
text?
Mahal. Yes.
Yes. Okay, so it's your problem then, not the problem here. Whatever your name, Muhammad Shafat Shaheen, the sound is okay. It's your problem, not our problem. So what is the best PEEP then? The best PEEP depend on how much flow, volume, and pressure needed to achieve the PEEP. So always remember to keep the PEEP above the closing pressure. What is the closing pressure? Is the pressure need to close the alveoli, to collapse the alveoli. Below it, the alveoli will collapse. Above it, the alveoli is open. So that's what's causing, PEEP should be above the closing pressure. Can you please mute your mic? Second, the best we prevent intrapulmonary shunt because it causes very good contact between. Please mute your mic, everybody. Please mute your mic. So when you have a good contact between the pulmonary and the alveoli, you don't, if you have alveolar size less than the pulmonary vessels, then you get a shunt. If you have more, you won't get benefit, but you get a side effect of distension pressure of the alveoli, or what they call it paratrauma. So the best PEEP is to prevent intrapulmonary shunt, and then you get better oxygenation. When you increase intrathoracic pressure, you maintain the hemodynamic. Amr, you need to write your full name. Amr what? I will remove your name after 5 minutes if you do not change your name. So increasing intrathoracic pressure also maintain a good hemodynamic stability of the right and left ventricle. However, if you use excessive, more than need PEEP, you will interfere with the venous return to the chest. You will interfere with the preload. And if you drop the PEEP and your oxygen drop, but when you increase, your oxygen improve, but you get hypotension. So the solution here, you give either inotropes, if depend whether your problem is in the heart or in the vascular bed, or you give normal saline if you have kind of depletion or dehydration. So again, what is the best PEEP? You have inspiration. Here is you have a pressure. Here is your volume. So it's a parameter. Again, it's parameter, one respiratory cycle. Then this is a loop. Yasser, you need to put your full name. That's the last time I will allow people with one name, one typing name to enter the group. So you have a volume and you have a pressure. And it's a one cycle, then this is a loop. This is inspiration, and this is the pressure. This is volume. This is the critical opening. This is the point where we open the alveoli. This is the point where you reach maximum opening of the alveoli. This is a pressure, this is volume, this is inspiration. So it's volume against pressure, one cycle. It's a hemodynamic of one respiratory cycle. This is a loop, not graph. Inspiration, pressure is moving up, there is no difference in volume, moving a little bit up, volume is increased until you reach the opening point of the alveoli. And then you go up, you reach a point after which there is no more opening. It's just a side effect. Then you get expiration. Here, after this, if you move less than this, you can see there is no volume in here. There is no volume in here. If you reach this point, the alveoli will collapse. What we call it a critical closing point or upper inflection point. And this is lower inflection point. So here you get deflation. Here you get over distension. This get distension without contact with the pulmonary vessels. Here's less contact with pulmonary vessels. Here's the best area. So this area is deflation. This area causing intrapulmonary shunt. Dr. Qadriya, please you remove the title doctor from your name. And here you get over distension. Here you get over distension. Here you get under inflation, where the alveoli is smaller than the actual pulmonary blood bed. So you get intrapulmonary shunt. Here you get over distension, or what we call it peaking of the graph. Here's your safe area. So injury here because you are de-recruiting. Injury here because you are de-recruiting. Injury here because you are over distending. Safe area. Okay, we have a person is asking us question. Who's raising your hand? Can you speak if you want? Whoever raising the hand, can you speak? Hello? Whoever was raising his hand, do you want to speak? Okay. Anyhow, whoever was raising her hand or his hand, do you want to speak? Who has a question? Do you want to speak? Text me better. Qadira, text me better because your background is noisy. Okay, so again, what is the best PEEP? Another graph. You can see this is the PEEP, and this is inspiration. Here's the over distension. Here is under distension. So when you give good PEEP, this zone under recruitment, the collapse zone will get less and less. So when you move it, you get better alveolar recruitment, or the lower inflection point, or critical opening point. When you drop your PIP, you get less over distension, less peaking. Okay? Again, inspiration, expiration, targeted volume. You can see the graph become planted. That means we are using a volume guarantee. And you can see the shape is better. There is no de-recruitment. There is no peaking. So very optimal PEEP. So when the graph moves in this direction, when the graph moves in this direction, to the right, toward the pressure, okay, mean more pressure, less volume, then you are over distension. When you move to this way, you become closer, you are de-recruiting. So you need to keep your pressure volume loop in the safest zone. That is the best PEEP. If you go this way, you are giving over PEEP. If you are giving this way, you are getting worsening PEEP. So titrate your PEEP to get optimal loop, and titrate your PEEP to get the best saturation with the lowest FiO2. When you set your PEEP, there is a ventilation strategy. What is the ventilation strategy? You want to treat inadequate oxygenation, and you want to get better ventilation. And ventilation means you're washing CO2. And oxygenation, you're giving better oxygen. And you need oxygenation usually when you have lower airway disease. And then you need to also affect your ventilation setting. This is mistyping. While inadequate ventilation, it happens when you have ineffective ventilation. If you have a monomuscular, you have a brain problem, or when you have obstructive disease, you get less or inadequate ventilation, like asthma or bronchiolitis. Now, what is the initial setting? We talked about PEEP. What is the best PEEP? Now we'll talk about PIP. PIP in neonate, well, it depends. You're using VG or you don't use VG. Most of ventilator has the ability um, so I'm not allowing any person without actual real name. So people are coming with not their real name now, they're not allowed to come in. If you're using VG, then you have to use 2 centimeters of water above the pressure that achieve your your VG. Again, if you're using VG, then use 2 centimeters of water, PIP, above the pressure required to achieve that VG. VG is volume guarantee. If you are not using VG, PIP is peak inspiratory pressure. We have already talked about basics of ventilation. Today is not about basics of ventilation. I'm not going to talk about basics of ventilation. Um, okay, so if you're using VG, then use 2 centimeters of PIP above the PIP required to achieve your VG. If you are not using VG, then the pressure usually in neonate between 20 to 30. So if you have about 25 weeks, you usually need 20. You might need mid 20 if you are in 30s, and in term baby, you might reach up to 30. And remember, this is initial setting. Probably you can go higher and later on. In infant, the initial PIP without VG is about 16 to 25. In adolescent, it's about 18 to 25. And again, you might need higher when you have lower airway disease. Inspiratory time is the time or the percentage of inspiration from one respiratory cycle. So if your rate is 20, your one respiratory cycle is 3 seconds. So if your inspiration is 1 second, then you're 33% time or 1 second. So usually because the rate in neonate is high, it's 60 and the cycle is 1 second, usually the inspiratory time is between 0.2 to 0.4 seconds. This number PIP above PEEP, what does that mean? I don't understand the question. What's the relation between PEEP and PIP? There is no relation. PIP has nothing to do with PEEP. It's a PIP and PEEP. So different numbers. Go to basics of ventilation and look at it, please. So TI is PIP is a peak inspiratory pressure. It's a pressure during inspiration. PEEP is the pressure need to keep alveoli open. They are two different numbers. So the TI in infant and child go longer because the respiratory rate goes down. So it's 0.5 to 0.6. In adolescent, further the rate goes down to 12 per minute, and then your inspiratory time goes longer. VG or volume guarantee, and VG is used with all type of ventilation. So you can have assisted control VG or SIMV VG or CMV VG or PSV VG. So the VG in neonate is about 3 to 0.5 mil per kg. While in infant and adult, you can reach up to 8 mil per kg. However, when you have a leak, which is the air escaping between the tube inside to the outside, you might give VG higher. And sometimes you reach to a point, the leak is like 50%, you have to turn off your VG. You cannot use VG. And then after you set your PIP, you've set already your PEEP, PIP, inspiratory time, VG, you need to go the trigger. And you have two type of trigger, time and flow. If you want to rest the patient, use time. If your patient is weak, coma, premature, muscle paralysis, use time. If you want the patient to and remove and give exercise to the chest, and you are not afraid from exhaustion of the respiratory muscle, use flow. And usually the flow is from 0 to minus zero point 0.2. That's mean when the patient starts to inhale 0.2 liter, the machine will help. And remember, trigger is only for assisted breath. Remember, we have three types of breath: mandatory, spontaneous, assisted. So trigger is only for assisted. And the time, it can be zero point 0.0 second, or you said if your respiratory cycle is, if the respiratory rate is 60, then you have 1 cycle per second. Then you tell the machine right away, the machine will understand that each 1 second it will trigger the patient, because the machine needs to give 60 rate per minute. So you've set your PEEP, your PIP, your VG, and your trigger. Then you need to give your FiO2. And the FiO2, or fraction of inspired oxygen, yes, trigger is. So if you are mandatory, you don't need to trigger, because the machine will give you. You don't need to trigger. Trigger mean who will start the ventilation. So if your machine is triggering, then when you have rate, you get your trigger. But if your machine is, let's say, you're giving a rate of 10, and the patient is breathing 60, and you're giving, like for example, assisted control, the patient needs to trigger the machine, because the machine is not triggering, machine giving in a cycle. So when you need to trigger, you need to are talking about assisted one. If you are giving only mandatory, the machine will go automatically triggering. So if you are on a mandatory, usually you use time. So when you put the time, the machine will trigger every 1 second. But if you want to patient trigger, either use time or use flow. So FiO2 is you titrate to achieve. What's your, and I'm Surah, we can chat later at the end of the, we can chat or on the end of your, so please keep your question to the end, because too much interruption will, maybe others will not receive the presentation as good as it should. So you need to titrate your oxygen to keep your saturation. And then after you set all, you need to select your mode, what you are using. So the best for you need to use assisted control. And if your baby is strong enough, if your baby is not premature and you are short ventilation, you might give pressure support, PSV, and always add VG in neonate. Never ever use neonatal ventilation without VG, unless you have a huge leak. In infant and child, use volume control, and always add PSV. So whatever the mode you use PSV with it. So if you're using SIMV to give the patient what is mandatory, if the patient is breathing above that you give it as PSV. In adolescent, use volume control. And the reason why volume is better for infant and children, because their alveoli is already distended. So the risk of volume is less, not like in neonate. Not like in neonate. The risk of volume is high because the alveoli are stiff. At the same time, when you have lower airway disease, you might think of giving pressure control, not volume control, even in adult and infant, because of tightness can cause trauma, especially if you're ventilating for a long time. Khalid, please mute your mic and your camera. Thank you. So now you need to set the rate. The rate usually is 30 to 60 in neonate, in infant is 20 to 30, in adolescent it is, please mute your mic. Please mute when you go in, mute your mic right away. So in neonate, you get 30 to 60 the rate. In infant and child is 20-30. In adolescent goes down to 12. Now, what is the best PEEP in neonate? Remember, this is the starting, is 3 to 8. In infant is 3 to 6. In adolescent is 3 to 5. So you can see it's wider when you go lower age and become narrower, the two extremes, when you go older. When you start ventilation, you need to consult somebody who understands ventilation. And the golden principle, when you set, assess after 15 minutes. If you're achieving your goal oxygenation, your saturation, you reach the target, and what's your blood gas. And you need something called pressure support. The pressure support is a parameter to give the amount of the air or the pressure inside the ETT. So the larger the ETT, the less pressure support you need. So in tube size 3 to 3.5, the pressure support in the machine should be 10. When it's 4 to 4.5 tube size, it's 8. When more than 5, you need 6 centimeter of pressure support. Because when you have a tight tube, you get very difficult flow. So you need an extra support to move the flow in a very small, like 2.5 size tube. Always wean oxygen first. So always your target in neonate less than 30%. In infant, child, and adolescent, your target should be less than 40. FiO2, the percentage of FiO2. Your target saturation should be 92, 97. If your PEEP less than 10, but if you need higher PEEP, you might decrease your target between 88 to 92. So again, you start with 100% wean quickly to go to 40%. Start with 100%, wean quickly to 40%. Put your target to 92 to 97, your target saturation. If you are using PEEP less than 10, if you need PEEP more than 10, then it's better to compromise and drop your target 88 to 92, so you don't give more. And especially when you have a difficult, stiff, non-compliant alveoli, like in RDS and in like in neonate and when there is adult respiratory distress syndrome. The initial setting when you are using a volume control ventilator, tidal volume, we talked about it, it's between 5 to 8 mil, whatever the gestation is. If you're using lung protection strategy, you might go down to 3. You're compromising to protect the other if you're ventilating long time. The rate in volume control, that's why we don't like it in neonate, should be 20 to 30. And it goes down to 12 in adolescent. PEEP, again, it's 3 to 8. And remember, this is the starting. Pressure support is the pressure needed to move the flow through the endotracheal ETT. So the minimum in babies less than 1 year is 6 to 10 centimeter of water. Joeria, please use your full name. Joeria, please type your full name. I allowed you to enter today, but not anymore. So again, the pressure support is the pressure need to move the flow in the ETT. So when you get smaller, you need less pressure. But when you're using the volume, the pressure support is the same. The PIP is the peak inspiratory pressure. It's the pressure during inspiration. Always adjust to fit the inspiratory time, because the higher you go in the PIP, the wider inspiratory time you need to do it. So in volume control, you don't go PIP like the pressure, because you remember that you control the tidal volume, but you don't control the PIP. The PIP should be free. And that's why volume control can cause barotrauma, because you need more pressure. So you cannot set the PIP in volume control. You need to set a pressure to fit the inspiratory time, because if you give lesser pressure and give wider inspiratory time, there is a period there will be a pause, there will be no flow, no movement. The inspiratory time in volume control is zero point 0.4 to zero point 0.5, so longer because respiratory rate is less in neonate, and it goes higher when you go older. FiO2 always start with 100% and wean. Not in neonate. In neonate, use either room air. It depends. In term baby, you can use 30%. The flow trigger, the flow that we talk about, if you use a flow trigger in volume control, it's 0.2 to zero point 0.5 and goes more. The flow means that how much the patient will breathe in before the machine will help. And if you're adding PSV to the volume control, PSV usually added for spontaneous breath. It's about PSV, or the pressure is about 10 to 25% of the PIP needed to fit your inspiratory time. It's 10 to 20 of your peak flow rate. Now, initial setting in pressure control, now you don't have tidal volume. You only set a PEEP, and you can go up as, oh, this is PIP, sorry, not PEEP. Here is wrong. This is PIP. So your PIP is 16 to 25, 16 is same. Your PEEP is 3 to 7, same. Your rate is 20 to 30. In neonate, you go up to 60, and the rate goes down to 12 when you're adolescent. In inspiratory time, the older you go, the higher the inspiratory time. iPhone Hussam, please try to put your full name. This is the last time I allow people with abbreviated or nicknames to go to the room. So pressure support, remember, this is the pressure need for the special ETT. So it depends on the baby, because smaller baby, you get smaller size, so you need a higher pressure. But in pressure control, usually you need almost same pressure. FiO2 always start with 100%, then wean. Trigger, flow trigger is the same. Pressure support is the same, 25% of the inspiratory pressure. The PSV, which is the mode or the hybrid or a combined mode with the pressure control, whatever the mode of the pressure control, using like assisted control or CMV or CMV. For the spontaneous breath, use addition PSV, and it should be the PSV pressure, because remember, in PSV you only determine the PIP and the rest is done by the patient. You don't need to set anything unless you put a backup rate. So usually the PSV is 10 to 25% of the PIP. When you use a pressure control, always consult an expert. Remember that. And the pressure support we talked about, the oxygenation we talked about. There is sometime when you do initial setting, there is special circumstances in initial setting. In asthma and bronchiolitis, the most important in asthma and bronchiolitis is to fully control. Use a good PEEP. Prevent leak. So cuff tube is better for asthma. Higher pressure is better for asthma. Fully control is better for asthma. Maybe you need a paralysis and sedation more in asthma and bronchiolitis than other problems, because you need. So assisted control might be not a good mode for asthma and bronchiolitis. CMV, fully control, or SIMV is better because you don't need to exhaust the patient. In diabetic ketoacidosis, you have dehydration and you have metabolic acidosis, so you need to wash more CO2, so maybe the rate is higher. Maybe also you need to use less pressure or give more volume because of the preload. Salicylate toxicity, you already hyperventilation, so if you use SIMV, because that will be mandatory and spontaneous, then your rate may goes up to 70. So if you have salicylate poisoning, use only CMV. Don't use PSV, don't use SIMV, don't use or use any mode that has no assistance. Because when the baby or the patient has hyperventilation because of the salicylate, then he will wash more CO2 and the machine will help him if you're using assisted breath. So remember, in salicylate, you should not have assisted breath. You should have paralysis. The best is midas and lorazepam. Lorazepam is for scheduled interrupted doses, and midas for better continuous infusion. Diazepam is not advisable. And remember, lorazepam can cause myoclonic jerk in babies less than 32 weeks, so it might be not a good option. So benzodiazepine is a good option for sedation. Remember, depend on your patient. So you need to get good sedation. For example, in asthma, you need fully controlled, but not pneumonia. So you need to, you need to use fentanyl or carfentanil or morphine. Has both sedation and they are narcotic. Both sedation and um, sedation and analgesic at the same time. And remember, when you use benzodiazepine and you have assisted breath, remember it will goes down. So if you depress the respiratory drive, remember that your assisted breath will goes down. Same for sedation. Ketamine is very good because it has a bronchodilator effect, so it might be a good option for asthma. Dexmedetomidine is alpha stimulant. It's like a clonidine, but it's a shorter, and it's a very good adjunct sedation to decrease the need um, for analgesia and sedatives. How to maintain ventilation? To maintain ventilation, you need blood gas. You need to have the CO2 within normal, and usually I don't like the term normal. What I like is permissible. What is your permissible CO2? And your SAT monitor that we talked about. And remember, oxygenation increase when there is better MAP. And MAP is mean airway pressure. And it's a collective pressure under the curve. So you have PEEP, PIP, and PEEP. So anything above is the MAP. So the MAP is equal to the flow, to the time, to PEEP, and PIP. So therefore, any parameter affecting the MAP will improve the oxygenation. So you can increase your FiO2, you increase PEEP, inspiratory time, your PIP, and when you increase your PIP, if you are using volume guarantee or volume control, you might need not to change your PIP, you might need to change your tidal volume. While if you want to do ventilation, you increase the breath rate. So either you increase your respiratory rate, and if you're using VG or volume guarantee, you increase your volume limit. If you are not using volume and you're using PIP or pressure control, you increase your PIP. And remember, PEEP prevent collapse and prevent intrapulmonary shunt. It recruits the collapsed alveoli. It increase or stent also the upper airway. So when you have upper airway problem, like bronchomalacia, you might need to give better PEEP to stent the upper airway. Now, what is the patient, when there will be patient ventilator asynchrony? When there is obstructive lung disease, there will be what we call it auto PEEP or PEEP-I. What does that mean? Remember, you have PEEP and PIP. And PIP should goes back to the original PEEP before the next breath start. If the next breath start prior that, then your PIP, the previous one, will not reach to the PEEP. And there will be a gap between the PEEP and the starting of the new. That's what we call it auto PEEP. So if your second breath started earlier, you might have additional PEEP because your next PIP started before the previous PIP dropped to the normal. Okay, so when you have obstructive lung disease, you might need to give a longer expiratory time to give time for the PIP to reach to the PEEP. That's very important to remember. The second, when you have obstructive lung disease, you are not able to create negative pressure. And therefore, making the patient trigger the ventilator is not a good idea. So it's better in this situation to use non-trigger breath or mandatory breath. Otherwise, you will waste breathing effort. It's also when you have this situation, you might give better sedation and muscle paralysis if you need. And so you're wasting the breath, you're exhausting your patient, and you're causing patient distress. The second asynchrony is when you increase resistance. And resistance increased in the, when we say resistance, it's upper airway. So when you have, like, not only upper airway, but the airway, not the alveoli. So resistance in the airways. So if you have a constriction like bronchiolitis or asthma or edema, what you need to do to decrease resistance is to give better PEEP, because when you give better PEEP, the PIP will need less to go up and down. So remember, when you have increased resistance, improve your PEEP. Now you might have flow asynchrony. You might have fixed flow in volume control, because remember, pressure is the peak of the flow, while volume is the duration of the flow. So if you are giving fixed flow, but you're increasing, because in volume control, you don't need to change the flow, the peak of the flow, because it's all about the duration, whatever the flow you're giving. And therefore, in volume control, you only use fixed flow. So you don't need to change the flow. What you need to do when you have asynchrony, you change the time, the duration. While in variable flow, when you have a pressure control, or what we call it reverse ventilatory control, then what you need to prevent auto PEEP. So remember, look at your graph, not the loops, the graphs, which is the pressure versus time, and your PIB should goes always back to the original PEEP. If it does not go back and the second start, then you have an auto PEEP. How you terminate asynchrony? There is difference between patient inspiratory time and ventilatory time. So you need to change it to match it, depending on the gestational age, and the disease process. You need to prevent auto PEEP. And also when you have PEEP, mean that the patient PIP effort is less than the original PEEP. And also when you have increased resistance, like in bronchopulmonary dysplasia or chronic obstructive airway disease. And also in asthmatic patients, very important. And also asynchrony is very commonly occur in PSV. The reason for that, because as you remember, PSV is you're only giving pressure, and everything else is controlled by the ventilator, the rate, the trigger, the PIP, the volume, everything controlled by the patient. So you're only giving PSV. And because of that, the patient needs to do much effort to synchronize and drive the machine. There will be much asynchrony during that time. And that's one of the reason why the PSV can exhaust the patient. And therefore, it's not good for obstructive lung disease or for premature babies or ventilation for a long time, because you'll get asynchrony and you'll get tired because he's driving. Imagine the PSV is somebody is pulling the car, while CMV is somebody is driving the car. So that's the difference, how difficult is the PSV on the patient. Again, if you are using PSV and giving sedation, that's not a good idea. So we talked about asynchrony regarding the pressure and the volume. Now we're talking about expiratory asynchrony. And expiratory asynchrony can occur when you have short expiratory time and when you have long expiratory time. And usually the ratio should be 1 to 2, 1 to 3. Very unlikely do you need more unless you have a real disease process. So anything like, let's say, 1 to 4 ratio, inspiration, expiration, you get longer expiratory time, and 1 to 1, you get shorter expiratory time. If you get ventilator asynchrony, sometimes your machine is not responding. You have a problem with the machine. And remember, expiration asynchrony can cause hyperinflation and can cause air trapping. And remember, if you look to the graph of the flow, always the graph should goes back to the zero before starting a new flow. If it does not go back to zero, whether it's a flow, or whether it's a graph or loop, if it does not go back to region, remember there is air trapping. And that means you have expiratory asynchrony. So you need to adjust your expiratory time. Now, after you've set your mode, your type of ventilator, pressure control, volume control, SIMV, PSV, whatever your mode, you've started PEEP, PIP, rate, trigger, variables, you've done, you need to adjust your initial setting. So it's always a good idea to do a gas after, let's say, 15 minutes, and also maybe you need an X-ray, and also you've checked your graphs and your loops, and then you adjust accordingly. So if you want to adjust, use what we call it lung protection strategy, like in patient with pediatric adult respiratory distress syndrome, then always adjust your PIP to achieve your tidal volume. So you set your tidal volume using VG. If you are using volume control, it's a tidal volume. But if you're using pressure control, you are adding VG. So always adjust your PIP to achieve your VG. And you should never exceed 10 mil of VG per kg. If you're using volume control, it's a tidal volume. If you're using pressure control, you add volume guarantee to it. You might need to reach higher PIP up to 40% if you have very poor lung compliance. Again, before you reach that, you need to give very good PEEP. And the maximum PEEP that I use is 15. I never go above 15 of PEEP. Also, you might need to compromise. So you might need to decrease your target oxygen saturation instead of above 92 to 88. And also you might need to compromise and give wide range of your blood gas if you're using ABG. So there are many people coming with their not real name, so I'm not allowing. There are about 10 people are trying to enter, but I did not allow them to enter because they're using fake name or nicknames of their mobile. So you need to change your mobile name to your real name before I allow you to come in. So again, when using lung protection strategy, remember these. When you want to adjust for obstructive airway disease and you have ventilation problem, that's mean your CO2 is higher, like in status asthmaticus or in bronchiolitis, you need to probably shorten your inspiratory time. So either use low or normal and extend your expiratory time to prevent the auto PEEP and allow the PIP to goes back to normal. Because remember, when baby breathe in and then want to breathe out, if you look at the pressure curve, the curve goes up, reach the top, and when it start to goes down, it's still in the airway until it reaches the plateau phase, and then goes down to the PEEP. Above plateau phase represent the airways. Below the plateau phase represent the alveoli. So the alveoli need to be fully expand, or the time between the plateau phase and the PEEP. If you don't, the PIP does not have that time, the next respiratory cycle will start and you will get auto PEEP. So it's very good always to use a good inspiratory time, lower than normal, and expand your expiratory time, and your ratio may reach up to 1 in 5. And remember, PIP should be above plateau pressure. So you should see a peak, then plateau, then back to the PEEP. If you don't see only the plateau, then you are using less pressure. But remember, never exceed 40 centimeters of water. And remember, use permissive hypercarbia. So you can allow CO2 of 60, 70, and sometimes even allow 80 if my pH is more than 6.2, assuming that you don't have metabolic issue, like combining. So always do not excessively ventilate and allow permissive hypercarbia. And remember, when you have hypercarbia, the patient will breathe fast because want to wash CO2. So use good sedation to prevent hyperventilation. The other adjustment is when you want to protect the airway. So always use the minimum setting to achieve your oxygenation goal. And by doing this, you will prevent lung injury. Because if you're using volume pressure control, your volume will be variable and you will cause volume trauma. If you're using volume control and your pressure will be variable, you're causing barotrauma. And volume control is when you extend the balloon excessively, and when you deflate, it won't go back to its normal shape because it's stretched. That's volume trauma. While pressure control is giving more pressure in a room, and then that pressure will break the weak area in the wall, like let's say the window in the room or in the alveoli, causing barotrauma. So you need to use the minimum pressure to protect the airway, what we call it airway protection strategies. Now remember, when you have a problem with ventilation, remember DOP. D mean displacement of the ATT. ATT went up above the clavicles, went down to the carina, or even you're selectively intubated one side, or you have obstruction, it's kinked, or excretion, or you have a pneumothorax, or your machine is not working whenever you have troubleshooting. If you don't know what's the problem, disconnect and give hand ventilation. If you're hand ventilation and you're still deteriorating, then the problem is not in the ventilator, the problem in the patient. So either your tube is extubated above the clavicles or in the esophagus, or it's on one side, or you get complications. You get collapse, you get hemorrhage, you get pneumothorax. So what do you do in this situation? You have a ventilation patient, have a respiratory distress, or become hemodynamically unstable. Disconnect from ventilator and do hand ventilation. If your disability resolve, the likelihood you have a problem in your ventilator. So check it or call somebody to check it. If your problem does not resolve and the patient continue deterioration, then look for life-threatening situations or problems. Tension pneumothorax, tube displaced or obstructed. You get intrinsic PEEP, so you need to prolong your respiratory time. You get cardiac problem, so do chest X-ray, do blood gas, and do ECG. If you continue to deteriorate, Dina Gabr, please mute your mic. So assess if you continue deterioration, no, you're improving, then assess your manual, your ventilator. Um, when you give hand breathing, especially if you're using flow inflation valve, look how much pressure you are giving to ventilate the baby by your hand, because it's very likely that you're giving more pressure than the ventilator. You need to assess and then adjust your ventilator. So if you're doing hand ventilation and your patient is improving, then the problem is either you have a problem in the ventilator, or if the ventilator has no problem, then probably you're giving pressure more than or better than your machine, and then you need to adjust. Okay? So always remember, if there is air leak around the HET, if there is, because when you give better pressure, you are compensating for that air leak by your hand. Or sometime you need to do suction, or sometime you need to deflate your stomach. And if with your manual ventilation, you have difficulty to ventilate, as we said, check your ETT, replace your ETT, see the path. If no, there is no difficulty to ventilate, then pass a suction catheter. If your suction catheter passes, then you have a problem with your ATT. Either your ATT Patient is biting it, or it's kinked or twisted or obstructed because you're able. If you are not able to pass, do some suction and do another ventilation. If your problem resolve, then you might need to adjust your setting. Mostly you have intrinsic PEEP and you need or you need to give more sedation. If does not improve with all that, then your disease process is warning, whether it's your pneumonia or asthma, so you need to add more medications, diuretics, bronchodilators, whatever you're doing. Sorry, this is also typo error. An assessment of airway pressure during mechanical ventilation. You have high PIP. What is the problem? As you remember from the graph starts from PEEP, goes up until you reach the top, then start to goes down, and then you reach plateau, and then goes down back to the PEEP. The area from the top to the plateau represent airway. Never forget that. And between plateau and the PEEP, it represents the alveoli. So if your PIP is high, does your plateau pressure is high? Mean the pressure below the plateau is high and the pressure above the plateau is low. And that's mean if yes, then you have uh, um, airway problem. You don't have alveolar problem, which mean either pneumothorax or edema or atelectasis or anemia, or you are intubating one side. If your uh, if your if your plateau is elevated, that's mean your airway pressure is very short, which means it's good. So if yes, and your plateau is up and your the pressure below plateau is high, then it's an alveolar problem. If no, the plateau pressure is low, then it's an airway problem. So you should have either bronchospasm, mucus plug, and ATT obstruction. Now, maybe I confuse you, so I'm going to repeat this. You have top PIP, and then you have plateau. Above is the airway. Below is the represent the alveoli, and from plateau to the PEEP. Okay, so if your plateau is high, mean the airway pressure in your alveoli is low, and in PEEP is high, in the alveoli is high, because your plateau going up, shortening the airway, prolonging the alveoli. And that's mean you have if yes, mean you have alveolar problem. So you have this problem. If no, then it's an airway problem. If your PIP is not elevation, you have low PIP, then probably you are leaking. So either you're you should use the ventilator to adjust the leak, or you should use cuffed tube, and maybe your balloon is not inflated well, or maybe your tube is not outside. If your PIP is no, and your PIP is not dropping, then probably you have pulmonary embolism. Okay. Now, other causes of abnormal gas, you might have ETT problem causing obstruction, causing high CO2, so you get high and low CO2. I don't want to discuss this. It's very easy. It's mechanical obstruction. And you can disconnect, putting calorimetric CO2 detector to see where you are in the airways or not. If you have a ventilation oven, if you are over ventilation, and you have a high saturation, then probably you might need to drop FI2, drop PEEP, PIP, time, rate, flow, whatever you can wean. If you obviously, if you are over ventilating, your CO2 is low, so you need to drop here. You're over ventilating, but saturation is high. So, and remember, oxygen level or high oxygen is more important than low CO2 or high CO2. So when your oxygen is high, then probably you need to first wean your FiO2 and then your PEEP, because that's will cause you most of damage. And then you need to decrease your TI, giving more time for expiratory time, dropping the rate, decreasing the flow. But if your only CO2 is low, then your rate is a problem. After the rate, you have options to you decrease your PIP, you decrease your expiratory time, or decrease flow. When you have insufficient respiratory support and you see your patient, your chest is not moving, then it's PIP. Or if you're using volume control, need to increase your tidal volume. If you are adding VG and it's a pressure control, then you need to control or adjust your VG. Your oxygen, again, it's the same. We talked about it. If your CO2 is high, then you need to increase the rate. You increase to PIP if you are not using using pressure support. If you're using pressure support with VG, you need to increase your VG. If you're using volume control, then increase your tidal volume. Again, CO2 is high, you can increase the flow, rate, expiratory time, and also you drop the PEEP. When you drop the PEEP, automatically you're increasing your PIP. This is a graph. I'm not going to go through it. You need to adjust accordingly. Other causes, ventilator agitation. Remember, agitation, sedation. Always adjust your ventilation eyes. Opposition of the ATT can cause agitation. Low oxygen or high oxygen can cause agitation. So remember your sedation. Remember, routine sedation is not recommended. Remember, agitation can cause by bleeding or not diuresing, ileus. Remember, the best sedative is diazepam is not advisable, but it might be in adolescent and maybe children less than 12. Lorazepam is a good scheduled doses. Midazolam infusion, fentanyl as a narcotic. Um, Remember also chloral hydrate is a very good option. Morphine is another option. Remember, when you change in your clinical status, you need to check. We talked about this complication. I'm not going to go through this because I've discussed it all. Now, how you wean the ventilation? The best is to start to wean from your FiO2. And always keep, drop your PEEP second after you wean the FiO2 and is less than 40, drop your PEEP. Always keep your saturation more than 5%. If you drop your PEEP and you're using pressure control, without VG, drop your PIP. If you're using VG, just drop the VG, you don't need to drop the PIP. Always remember, when you start to drop the VG, your CO2 will have a problem. So always check the CO2 to make sure that your CO2 is not going up. If the patient is triggering, dropping the rate might not be a good option. If you're using a mode that produce or provide assistance. Always guide your weaning by saturation monitor, blood gas, and FiO2 requirement. Complication, you can get poor cardiac output through higher PEEP, hypotension, so you might need a volume Remember, volume associated lung injury, you need to use lung protection strategy. Remember your PEEP and intrinsic PEEP or auto PEEP. And remember, when you have increased intracranial pressure, you need to adjust your ventilatory setting accordingly. To extubate, you need to normal sat. FiO2 should be room air. PEEP around 4 to 6. VG 3.5, not more than that. MAP should be at around 10. Rate always below the patient ability to trigger. You do always PSV trial for 30 minutes, only PSV. Let the patient drive the machine. Some people use CPAP trial. You don't have any reason to keep patient ventilated, like surgery. Try to keep the patient MPO 2 hours before and 2 hours after. Suction the stomach. Keep your intubations personnel and tools ready for possible failure of extubation and need for reintubation. And thank you very much. I am done. If you guys have any question, I'm happy to answer.
Please, I want to know the dose of chloral hydrate in units.
Oh yeah, the dose is you should start with again. You should provide the pharmacist with a good flat dose, but the best would start with 25 milligram per kg per dose, and you can give it Q4 to 6 hours, and it's very good to give it as a PRN. Sometimes I reach up to 35 milligram per kg per dose, but the good starting dose is 25, and you can give it up to four every 4 hours. But I usually leave that to the nurse, and I give it as a PRN. Now the question is, what is the meaning of keeping the trigger below the patient rate? So if you're setting the rate, you get, let's say you're setting the rate in the ventilator to 30, but you're looking at the machine, and the machine will count the mandatory, the assisted, and spontaneous is 60. That's mean patient is breathing 30 above the ventilator. That's mean the patient is triggering. The question is, asthma and poisoning, we will talk about special scenario next talk. There's no time for that. So we'll talk about scenarios, and we'll change the setting according to this area. We'll talk about asthma, bronchiolitis, poisoning. How many times between each steps in weaning period? It's hard to know. In acute baby, it's hard to know, but I would say not less than 1 hour. But if you have CO2 of 25, you need to act quickly, because you need to wean quickly, because less than 30 is not good for the brain, can cause IVH, can cause encephalopathy. If your CO2 is 100, you need to move very quickly. But if your CO2 and gas is within normal limit, then you need to expand that movement. So steps can be every 15 minutes to every 24 hours. The question is, the rate is wide range 30 to 60, which is the best 30, which is considered when we use 60. Okay, now in premature babies less than 30, I start with 60. If I use RSI, and RSI means rapid sequence intubation, I use rate 60 for 1 hour, then I drop it. Sorry for that. I use rate 1 hour, then I drop it to 40 after 1 hour. So we call it in our unit RSI setting. Most of the babies do very well with a rate of 30 to 40. However, babies like 24 weeker, 23 weekers, they need up to 60. Please mute your mic. I don't know why it's a problem to you mute the mic. Yeah, so RDS, meconium, apnea, it all depends. It all depend on, but usually in babies 25 we use apneas. Usually you need low rate. If your lung is healthy and you have only apnea problem, obstructive apnea, then your rate usually low, like 30 or meconium aspiration. It depends on the CO2. If your CO2 is high, then probably you need high rate. RDS again depend you gave surfactant or not. Then usually in RDS your rate is high. In weaning period, the weaning you start with FI2, then PEEP, then rate. If you're using pressure control, you wean PIP. If you're using pressure control with volume guarantee, you don't need to wean the PIP, you wean the VG. If you're using volume control, you need to wean only your tidal volume. Any more questions?
Yes, please.
Okay, ask.
Good evening.
Good
Sorry.
evening. Go ahead.
About the trigger.
Okay.
A trigger. SIMV and controlled ventilation. Both
Okay.
of them are a patient-triggered ventilation.
No,
Is that right?
No, that's not right.
SIMV. SIMV.
SIMV. You said M, mandatory.
No,
right?
no. SIMV.
Yeah, SISIM.
IV.
Yeah,
Yes?
S. Just listen. Let me keep it. You're saying
Yes.
SIMV. mandatory.
Yes.
S,
Yes.
so it's not patient trigger.
Not patient trigger.
No, but it's
No.
synchronized with the
Yes.
patient. So the machine will not give, so in SIMV, you will see two breaths, spontaneous and
And
mandatory.
mandatory.
And
Yes.
the S, when there is S, the always will be synchronized. If there is no S, there will be asynchrony. So when you
Yes.
have no S and you have asynchrony, you have two options, go to SIMV or give sedation. So
Okay.
SIMV means the machine will give only the mandatory. So if you set the rate to 30, the machine will give 30. If the
Yes.
patient breathes 60, the 30 will be only spontaneous. SIMV. Controlled mechanical ventilation, you will not
Yes.
see assisted, you will not see spontaneous, you will see only mandatory. SIMV, you will see mandatory and spontaneous. While in
Yes.
assisted control, you will never see spontaneous. You will see
Yes.
mandatory and you will see assisted.
Okay.
While in
Patient
PSV,
triggered ventilation.
correct. PSV, you will not see spontaneous, you will not see mandatory unless you put backup rate. So if there is no backup rate on PSV, then you don't see spontaneous, you don't see mandatory, you see only assisted because the machine will give pressure and the ventilator will. Sometimes you see mandatory in PSV if you put a backup rate.
Yes. What is the trigger?
Trigger is two types. Trigger is
No.
when.
Okay. Okay.
Trigger is
In
two types.
SIMV, what is the trigger?
You can have two types of trigger in SIMV, whatever you like. Trigger has nothing to do with the mode.
Either time or flow trigger.
Yeah, if the patient is good,
Yes.
if the patient is good, you use a flow. If the
Flow.
patient is sick or sedated or paralyzed or not on or long, you use time.
Time. But trigger is depend upon the machine used, not.
The trigger is
Yes.
for the
Yes.
mandatory. The trigger is for the mandatory breath.
The machine give, not we.
The trigger,
Yes.
the trigger is for the mandatory breath and for the assisted breath. The trigger is the mandatory.
Yes.
So,
But we cannot control it.
No, we can control it.
By what?
Well, if let me finish. Mandatory, you control it by time.
Yes. You mean time of expiration or respiratory rate?
If you there is two parameters in time: respiratory rate, inspiratory time, and IE ratio. If you set two, you get the third one. That's mandatory.
Yes.
So you already set the trigger for mandatory. For the spontaneous, like for the assisted, you assist either time,
yes,
or flow.
Okay. You mean that we can control? Yes.
Surah, there is other questions. I cannot just keep discussing with you.
Just that.
Okay.
You mean that the trigger can be controlled?
We can meet me and you and do it privately if you want. But I have to answer other people, okay? We can meet with you privately and answer all your questions.
Okay, thank you.
So I'm going to answer other questions. Regarding to bronchitis obliterans, why recommended high frequency in such cases? Oh, the high frequency is recommended in every case. If you use a pressure higher than using PEEP more than 10 and your MAP is more than 12 and your FiO2 is you're not achieving whatever the process, whether it's bronchitis obliterans or RDS, you need to switch to high frequency. So high frequency is not depend on the disease process, it depends on the requirement and the measured parameter. If you're using a good PIP, good VG, good PEEP, and you need 100% of oxygen, then probably you need high frequency. And if you use inhaled nitric oxide and use surfactant and still you need high frequency. So the high frequency does not depend on the disease process, it depends on how much setting you are providing to, and you're yet not achieving your goal. So the other question, in weaning period, can I start decreasing the FiO2 to 40%, then start? Yes, you have to have your FiO2 down to less than 40%, but it's better to be room air before you wean. If you're using low PEEP, like let's say PEEP of 8, I would go to, but if I'm using PEEP of 12, when I reach FiO2 of 40, I'm going to start to decrease the PEEP. So it depends whether your PEEP is more than 10 or lower than 10. If it's less than 10, then I would go to room air before I start to wean less than 10. If I am above 10, when I reach 40, I start to wean. So it really depends. The question is, please, we want another lecture with more details and special. Yeah, the next will be asthma, bronchiolitis, RDS, meconium aspiration. We can have 1, 2, 3, depend on that, because I don't want to make it very long. Drowning, yes, pulmonary edema, drowning, burn, increase in trachenal pressure. We can talk about each scenario and how to ventilate. So probably next time I will talk about asthma and bronchiolitis ventilation. And I hope that. And anybody of you want to meet with me privately to discuss more, I am happy to do that. He can put his camera on his ventilator and discuss his patient. Do a PIP 20 to 30 value depend on the disease process or depend on the gestation? Both. So usually if you are less than 25 weeks, you're lower 20s. Even if you are between 25 to 30, you are in a mid 20s. Usually if you are more than 30, usually, and you are in high 20s. And it's disease process, assuming you are not using VG. So I always advise you to use VG with your PIP. Don't depend on PIP. PIP, you can cause, in pressure control, you can cause volumetrauma because your tidal volume will be variable. So always, when you use a PIP, try to add VG. Meeting is already recorded and I will post it, but I will divide it to during the talk and the questions because it will be too long. We can talk about high frequency. There are two types, high frequency jet, high frequency oscillator. Yeah. Yeah. No, I can record it. I will record it and post it. Yeah, we can talk about high frequency at some point. In cases of pneumothorax, which parameter should be caused adjustment in unilateral and bilateral? Well, you need to drop your PEEP. It's better to go to high frequency if you have pneumothorax. You need to decrease your PIP and you need to decrease your VG. You need a chest tube if it's big enough. Yeah, you need a chest tube. You need to adjust your PIP, your PEEP, and your VG if you have a pneumothorax. If there is no more question, I'm going to conclude and I'm going to record it in 3 pieces, pre, during, and post. Okay? Well, thank you very much for everybody and God you bless all. Ramadan Kareem. Bye-bye.